Thank you, and good morning, good afternoon, everyone. We appreciate your joining us today. My name is Regina LaBelle. I'm the Director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown Law. I'm really excited about today's discussion, where we'll be talking about decarceration and treatment beyond the walls. This summer, this is the fourth in our summer series, where we've been focusing primarily on treatment in jails and prisons around the country. About 5% of individuals with opioid use disorder in correctional settings get medication-based treatment, which is the standard of care for opioid use disorder. So we've been focusing a lot on that for the last year and in our summer conversations. But it's also important, just as important, that we talk about how we build communities of care so that people, the only place they get treatment is not in correctional settings. And how do we build the type of treatment systems that are needed in our communities? I've been struck by the similarities that we're facing today when we talk about decarceration between today and the 1960s, when we discussed deinstitutionalization of mental health conditions, people with mental health conditions. Deinstitutionalization of people with mental health issues really plummeted in the 1960s due to a combination of factors, which included federal legislation, healthcare that provided people with the type of treatment they needed outside of institutional settings. So today we want to talk about that path forward. What can we learn from that time as we look at decarceration? And how do we set about intentionally building a treatment system so people with substance use disorders and their families have options beyond jails and prisons? As of 2017, there are about 1.4 million people who are incarcerated in America's jails and prisons. And about 60% of them have a substance use disorder. So we'll hear from three leaders in public health today and medicine who can talk about steps that we can take as we look at building the type of treatment system that Americans with substance use disorders need. First, we'll hear from Dr. Caleb Banta-Green. Caleb is a principal research scientist at University of Washington's Alcohol and Drug Abuse Institute. Dr. Banta-Green conducts research on opioid use disorder and overdose interventions and provides technical assistance and evaluation services for public health and safety interventions across the state of Washington. He's an epidemiologist and reports drug trends in Washington state. He has an MSW, an MPH, and a PhD from the University of Washington, and he also served as a senior science advisor at the Office of National Drug Control Policy in 2012. Next, we'll hear from Dr. Patrice Harris. Dr. Harris is the immediate past president of the American Medical Association and is a psychiatrist from Atlanta. She has a diverse experience as a private practicing physician, county public health director, patient advocate, and medical society lobbyist. Dr. Harris heads the AMA's efforts to end the opioid epidemic and has been the chair of the AMA task force since its inception in 2014. Dr. Harris spent her formative years at West Virginia at West Virginia University, and she is a recognized expert in children's mental health and childhood trauma. She's led efforts on both local and national efforts to integrate public health, behavioral health, and primary care services. She's also a fellow of the American Psychiatric Association. And then we'll hear from Michael Botticelli. Michael was most recently the executive director of the Graken Center for Addiction at Boston Medical Center and is also a distinguished policy scholar at the Johns Hopkins Bloomberg School of Public Health. Michael served as director of the National Drug Control Policy Office in the Obama administration, and he has more than 2 decades of experience supporting Americans affected by substance use disorders at both the state and national levels. Michael also is in long-term recovery from a substance use disorder. So we'll hear from each speaker, And then I'll ask a few questions. And finally, my colleague Shelley Weissman, the Associate Director of the Addiction and Public Policy Initiative at O'Neill, will ask questions that have come in from the audience. So we ask the audience to please put your questions in the Q&A box. So thank you. And first we'll hear from Caleb Venter-Green.
Great, thank you very much. I'm happy to be with everyone today. I'm not going to use slides. I am going to post some links into the chat as I go, so just keep your eyes open for that. And I want to start with a bit of an anecdote. So here in Seattle-King County area, we've had a heroin task force for several years, a very interdisciplinary group, about 32 folks from all different perspectives: public health, treatment, law enforcement, People's Harm Reduction Alliance, really diverse group of folks. And what's been nice in our regular meetings is we've gotten to know each other and create relationships and get some understanding of each other's perspectives, which created the opportunity to have the conversation that we had one day where we were discussing a law enforcement officer in South King County. He was talking about he had recently seen someone pass out in a car in a parking lot in the morning, and there was drug paraphernalia, and he arrested that person and took them to jail. And I as a public health social worker guy, not naively, but asked him nicely, can you tell me why you did that? And he said, well, I was worried about his safety, and that was the only thing I was able to do. I didn't have any other option. And so I asked, would you take advantage of another option if it were available? He was like, absolutely, please, I beg of you, but I don't know what they are or where they are. And so I think that is really important to understand. You know, is that universal for every officer? Of course not. But is it true for many people? I think it is. I think that the level of frustration in society generally, before this epidemic, with the previous epidemic and the one before that around addiction, is profound and also presents an opportunity to do something. So what I want to share is a bit about what are those better options that may be out there, and how willing are law enforcement and people who use drugs to actually utilize those better options. And so I'll start with law enforcement. One thing I think people are probably pretty aware of, but I want to mention it, is the Law Enforcement Assisted Diversion Program, which is a pre-arrest diversion program for those with low-level drug crimes, prostitution, crimes of poverty, started in the Seattle-King County area, and has really taken off nationally. I'm going to post a link here just to their national technical assistance work. And in fact, our Washington State legislature actually passed last year to open up several more LEAD programs in Washington State. So this idea about pre-arrest diversion, and of course the issue that will come up is to divert to what? In most instances, people are trying to create very low barrier access to often fairly traditional drug treatment. But what I also think is important are other things that are happening, and I think really interestingly we cannot ignore and should not ignore what's going on with the Black Lives Matter protests for racial justice, and some of these long discussed ideas are all of a sudden maybe coming to fruition. And an example here in King County is we had a long planned new big shiny beautiful, if you can call the juvenile detention center beautiful, juvenile detention center, and there was a lot of community protest to not even open it. But it did open recently, and with the Black Lives Matter protest, our county executive has come out and said that we will in fact now close this new facility and repurpose it within the next few years. So there is this opportunity to start doing some new things. I also think there's a couple of important insights to get from law enforcement officers on the ground. I want to share a couple of those briefly. We have a large SAMHSA grant with our state partners to distribute Naloxone, do overdose education in the state. We do most of that with people who use drugs in their social networks. But we also do that with law enforcement officers. And from 2017 to 2019, when we distribute these kits, we do basic surveying. And so we had over 1,200 officers. And we just asked them a few questions. I want to share the results of that with you. So we first asked them a very leading question, which I try not to do as a researcher, which was essentially, how aware are you of the evidence base for medications for the treatment of opioid use disorder? I said it a little nicer than that, but that's what I said. And about a quarter said they were very aware. About half said they were somewhat aware. And a remainder said they were not aware at all. So there was some awareness, but the most common was that people had a little bit of awareness. We then asked them about their willingness to do other things pre-arrest. How willing were you to refer people to treatment? Oh, people were very excited about that. 55% were very willing. 33% were somewhat willing. How willing are you to take a person to treatment? That drops to 37%. And 41% somewhat. I also think important context is, Well, what type of treatment? Treatment that they're not eligible for, treatment with a 1-month waiting list. So it's, that's kind of a hard question to understand. How much is the willingness versus their awareness of the real challenges with getting people into care in that context. So a couple other quick questions we asked folks. We also asked them about whether they wanted to work with an embedded social worker, and that's really interesting. I've seen that work nicely in some places. I think there's been a lot of talk about defunding the police and doing social workers instead, and it's really mixed about how willing officers are to work with a social worker, really directly embedded. That really changes their approach to their work, their workflow, who's in their car. It's a very different process. And I'm going to put up, these data I just mentioned are not public. I did share them at a DOJ meeting, so they're available, but if you're interested, just follow up with me. So the point is in that it's not a monolith. There's not one thing. All officers don't think one thing, of course. But there is some willingness and interest out there. And so I think it's important to really try to play on that, to try to find out where there is some of that pre-contemplation and work on that, because, they're human beings. They're impacted by addiction in their personal lives as well. One of the things, though, I think is the biggest challenge, and I find this generally in my work, and this is true whether you're police or physicians or whomever, is addiction's odd in that we're all experts, but we're mostly incorrect. We have incomplete understanding of this disease. And one of the most important misunderstandings is this idea that people have to hit rock bottom. It's a really widely held misbelief, and I think we often think about people failing treatment, but what I will argue, and what I think is very important in the context of our discussion today, is treatment is clearly failing people. So I want to talk a little bit about those people. One of the things that we've been doing for the last few years in Washington State is a statewide syringe service program survey, over 20 syringe exchanges, about 1,300 people. And what's important in that, we've published several papers that are available online, is a substantial minority. I think about 37% of people have been incarcerated in the past year, and we've shown what others have shown, is that it's associated with non-fatal overdose. We also know in other research it's clearly associated with fatal overdose, being incarcerated for as little as 5 days. Really importantly, again, documenting the obvious, most people who are opioid users want to stop or reduce their use. 82% of people who are injecting opioids say they want to stop or reduce their opioid use. Half of methamphetamine users say they want to stop or reduce their methamphetamine use. Yet, when we ask, have you needed health care in the last year and not gotten it, 60% say they've needed health care and not gotten it because of how they're treated by providers. That is a huge, huge problem. So people do want care. Our existing systems are often not where they are welcome and don't provide care that actually meets their needs. And I'm just going to post these 2019 survey data online. So we've been really working to take that information. Most people don't want to be using. They're not able to access successfully the systems that we have. So what do? So we and others across the United States have been developing low-barrier buprenorphine access programs, calling it medication first, or low-barrier buprenorphine, or low-threshold services, and so on. A lot of different things, but that fundamentally, the work that we're doing in Washington State is around low-barrier, same-day, drop-in access, almost always same-day medication starts, no prohibition for polysubstance use initially or ongoing, no counseling or other requirements or mandates, always offered. So it's really this idea about medications first, more when you want it, because we know that every day a person is on medications like buprenorphine or methadone, their chance of dying is cut way more than 50%. So we think about it as the most potent overdose prevention tool we have, as well as a lot of other added benefits in terms of quality of life and functioning. So we've been working on creating that, and I encourage people to take a look at the work that's happening across the country, whether it's Missouri or San Francisco or New York or Massachusetts, around low-barrier buprenorphine access. A couple of other things I want to mention, though. One of the real challenges, people are aware of the huge increases in methamphetamine use recently. And I think that methamphetamine presents a particular problem. And I should say a particular problem for the people who use it, because it is a harmful substance for many people, but it also has a lot of benefits. Fewer people want to stop their use. If you think about methamphetamine, it's a potent drug with a lot of bad side effects that people don't like, and yet on balance in the context of their lives, half the people injecting it don't want to stop their use. So what do we do about that? That really speaks to all the other factors that are driving that use, whether it's social, mental health, homelessness, those types of things. So we'll need to be thinking about that as well as we're thinking about how do we provide low barrier addiction treatment services, which really in the context of methamphetamine is really low barrier access to behavioral health, care navigation, supportive housing, and all of those issues. So just to wrap up a couple things here, I think we also need to recognize the context. We need to move quickly. COVID-19 has led to temporary decarceration. We have about a 50% lower census in our jails in Washington State. We do training for our jails around medications for opioid use disorder, so we talk with them monthly. But when we talk with these jail administrators, they're telling us these law enforcement officers are champing at the bit. As soon as this COVID thing is over and this decarceration thing is over, they are ready to start arresting people and fill those jails back up. So this is not changing that dynamic at this point. We're going to have to really be more purposeful at a systematic level. And then lastly, really, what then, right? If we're going to decarcerate, what are we going to do instead? And it isn't like, okay, great, we're going to save billions of dollars. It's like, no, we're going to repurpose those billions of dollars and undo all the damage society has created that has led to all of this incarceration. So this is a huge body of purposeful work that we really need to think about. And then the last thing I'll mention, we just hosted a conference I was very excited about. It's really our first meeting. We've had prevention conferences and treatment conferences in our state for 35 years. We just had our first statewide harm reduction conference, which we called Transforming Our Communities, Health, Equity, and Justice for People Who Use Drugs. It was a multi-sector, regional, and statewide meeting to really holistically create new ways to care for people who use drugs. And I'll post a link to that and all of our slides here for people to take a look at. So this is going to take a lot of work, a lot of conversation, a lot of listening, and I'm excited to listen to my colleagues. So I'm going to hand it to Dr. Harris, and thank you for your time.
Well, thank you, Caleb, and thank you. I think that was great in level setting. Just want to make sure someone give me the thumbs up that you can hear me okay. Just want to make sure. Very good, very good. Well, I am so happy to be a part of this discussion today. I've known Michael and Regina for several years, and as I was preparing for today, I was thinking back on the very first time I spoke at a meeting. I was on a panel. It was here in Atlanta, and we were talking about the opioid epidemic, and it was almost all law enforcement focused. And I remember walking into the room because candidly, I didn't expect that. Of course, each of us come to any conversation or any public health crisis with our own lens. And so I, of course, came with my psychiatrist lens, my physician lens, my medical lens. So that was very unexpected, but certainly I think it provided a learning moment for me personally, but I think all of us, because I think we can fairly say that we have made a lot of progress. Certainly we cannot declare victory, and Caleb just talked about a lot of the conversations we will absolutely need to continue to have. And certainly I think we can take advantage of the moment and have those conversations, and hopefully that will accelerate movement towards what we really should be doing. I will say that though, I've tempered my optimism on a lot of things because again, we just can't be optimistic. We have to really think about a framework going forward and a conversation and concrete actions going forward. But certainly we have made progress from those days when we looked at substance use disorder, in particular around the opioid epidemic from a law enforcement perspective, but clearly we have much more work to do. So I'll ask my team here in Atlanta to pull up my slides because I want to really even focus on the title. I was intentional. Regina talked about being intentional, and we should be intentional about this and so many other things that have been raised through this COVID epidemic. But it is about severing the ties, again, between the opioid epidemic, and I would say substance use disorder and criminal justice. But of course, that's necessary, excuse me, but certainly not sufficient. So I'm going to talk a little bit today about what we are doing at the AMA, what I'm hearing from the physician community. I want everyone to know that we are engaged, want to be engaged, and then really talk a little bit about a framework based on work that's happening here in Atlanta in a group that I am a part of here in Atlanta. But you just heard, hopefully, and this is not new information, that we have really evolved again from, even in the opioid epidemic, from mainly focusing on prescription opioids to illicitly manufactured fentanyl and fentanyl analogs, But you clearly heard Caleb talk about methamphetamine. And so we at the AMA are even changing our language. And I'll just say something about language that is so very important as we talk about substance use disorder. And I will say one thing too, that when I talk about behavioral health, I am including services and supports and an infrastructure for the treatment for those who have a substance use disorder. I think we can all say, and there have been good reasons that we've even sort of separated out mental health and mental illness from behavioral health. And I have to tell you that I would love for someone to even come up with another name for behavioral health, because I think behind that is a thought towards behaviors and not even appreciating substance use disorders as health conditions, as brain disorders, as I call them. And, you know, there are even some problems with using that. So the language is complicated, but I think that we all should always continue to think about language as we talk about substance use disorders, and also learn and grow together as we try to develop new language that gets us to where we want to be, but certainly doesn't stigmatize. But clearly here, we need to start thinking about overdoses and not just opioids. And even over the last several years, as I've traveled around the country, I would go to certain counties, even certain states, and they would say, appreciate that we have this opioid epidemic in our country, but what I'm seeing mainly in my county, my city, my state are problems with methamphetamine. So clearly we need to, and have even today, made the point about broadening how we think about overdose and substance use disorders. Now, again, there has been progress in the fact that we are not solely law enforcement focused on this, and there have been progress in other ways. And again, we can point to that progress, but certainly we should not take a victory lap here. There is much more work to do, but even among the opioid epidemic, as you saw, it's evolving. Opioid prescribing is down. Physicians, as I said, are engaged in this. The opioid task force that was convened by AMA in 2014, the whole purpose was to coordinate on what the physician community could do, better collaborate on what we could do, and then of course work with all of the stakeholders. And so we have seen some work and some progress. These are sort of 5 of the metrics that we decided to look at. Again, but progress does not mean victory. And we certainly need to think about how we move forward. And as we talk about the criminal justice system, you know, I think the statistics and the data probably are not surprising among the folks viewing this webinar today. Clearly, the ties between substance use disorder and the criminal justice system are longstanding. They still are in effect. Again, maybe decreased during COVID, but certainly we are not interested and should not be interested in going back to any ties after COVID. Now, let's be clear, and I'll say this in a later slide, there are some instances where in law enforcement, certainly a critical partner. We just have to make sure we are right-sizing the partnership, if you will. But the AMA has been focusing, and as Regina said, we probably focused a lot on this early on. We needed to focus on the intersection between substance use disorders and criminal justice. But again, at the AMA, we also wanted to make sure that we brought in the medical community and public health systems. And I don't think everyone necessarily automatically thinks about public health when we think about substance use disorder, but a critical partner. And part of the work that I did here in Atlanta when I led our public health department, but it is about comprehensive care. Certainly, it was critical for us to talk about the treatments for those with a substance use disorder when they were in correctional settings, and the AMA has great policy on that, model legislation on that. But even, and I heard this at a meeting, I was telling Regina this yesterday, I was at a meeting and someone mentioned the fact that for some jurisdictions, a treatment was more available in a correctional setting than without. And perhaps, and I think the person was being a little tongue in cheek, but saying, so perhaps, we should have people break the law. I think, again, a little tongue in cheek in order to get treatment. I remember being a little bit distressed about that. And I said, no, what we should do is make sure that treatment is available outside of correctional settings. So again, it's not either or, it's both and. There are folks who are in correctional settings. We want to make sure they get the treatment that they need. But as Regina said, we need to broaden our thinking about that and make sure treatment is accessible outside of being involved in the justice system. And certainly we will have to be intentional about that. Again, the AMA is very engaged involved in Good Samaritan protections, a piece of the puzzle. But certainly we need to, and as we will do today, is think about how we get to a better solution. I think we all would agree that stigma plays a large part in impeding solutions. Stigma has played a part. I'll say a little bit about this later, but certainly racism, structural racism, the intersection between our police departments, law enforcement again, and Black and Brown communities. So all of these have contributed to where we are today. As I talked about the opioid epidemic, and even when we were mainly focused on prescription opioids, I always made the point that, in the 80s, when mainly Black and Brown communities were affected, our response was law enforcement. And now, again, with mostly upper middle class, white communities affected by the opioid use disorder, treatment was the solution. And so we cannot forget that, and we have to be willing to talk about our past issues around actually everything dealing with health, but particularly around this. And so again, as we look towards solutions, we need to center equity. And again, I'll say a little bit more about the importance of centering equity. But again, just some recommendations from the AMA's opioid task force. Again, Regina asked me to talk a little bit about the physician community and how we have been engaged. Here are just some of the recommendations, because for the last couple of years, we have been laser focused on access to treatment. We need prior authorization. We need to remove prior authorization. Step therapy, fail first, you heard that, so that folks can get treatment. And we need to make sure it's evidence-based treatment. We need to enforce state and federal mental health parity laws. Some of you may be surprised. Parity laws have been on the books, at least federal parity laws have been on the books for over a decade. But as is so often the case, sometimes we fail to go back and inspect what we expect, as I talk about. And so we need to encourage our state health insurance commissioners to do so. Again, we need to remove barriers to pain care. That's specifically around opioids. Again, it is not enough to just say, physicians don't prescribe opioids. We need to make sure that the other alternatives to opioids, if they are deemed appropriate, are equitably available. Quickly about physical therapy. The solution is easy to write on paper, refer to physical therapy. But first of all, if you are referred to physical therapy, you most likely have health insurance. If you need to get to physical therapy 3 times a week, you need transportation, more copays, paid time off from work. So complicated as we think about a system going forward. But again, as you see our slide here, it is really all of the folks, and it's being in constant communication, but all of the stakeholders that will be required as we move forward. And so in our latest policy brief and progress report, we ask the question, what should a proactive, coordinated approach look like? We have to move away from this careening from crisis to crisis. Public health is engaged, should be engaged as we think about a prevention framework and we think about the data and surveillance. Data is important as we then target interventions in areas needed. And then again, it's about going back and inspecting what we expect evaluation. That's a core component of public health. And so what we should have a vision for tomorrow is an integrated, sustainable, predictable, and resilient system, not just public health system, but system. And here, again, as we are thinking about this, we have to think about all of the factors that create health. And we have to make sure that a framework includes discussion and interventions in all of these factors. And I think that's so important here because we can even think about race and ethnicity and practices and policies that are institutional that lead us to where we are. So quickly, just here in Atlanta, I'm a part of a group, and it's called the ARCHI, the Atlanta Regional Collaborative for Health Improvement. And here are all the pieces of a solution, appreciating and understanding equity, and making sure that equity is centered in all that we do, meeting people where they are, making sure we coordinate care with the individual in the center, making sure we are looking upstream, midstream, and downstream, making sure we have an approach that is coordinated in all of those. And again, overall, making sure that equity is centered in any approach going forward, and that substance use disorder and behavioral health are not seen as external to, but just a piece of an overall well-working system. So thank you. Look forward to the questions.
Great. Good afternoon, everybody, at least for folks on the East Coast. I, too, am really excited to be with longtime colleagues, both my fellow panelists and folks from O'Neill. Regina asked me to talk about kind of what's next here. So how do we take some of the advancements that we've made and continue to move forward, but also acknowledge some of the challenges that we have in front of us and keep moving forward. I want to pick up where both Caleb and Dr. Harris raised issues around stigma, and particularly the intersection between stigma, race, and sexism. And I want to do it by an anecdote. When Regina and I were at ONDCP, and largely within the law enforcement community, there were cries that we couldn't arrest our way out of the problem. Many states moved to enhance criminal penalties for pregnant women with an opioid use disorder. And I think it's a really good illustration, not just how we have to continue to diminish stigma, but to really understanding the role that race and gender, among others, play in the formation of policy. I'll first talk about, and this sounds rather self-serving, but the important role that federal strategy and federal leadership play in terms of our approach to this issue. ONDCP, as an example, was founded in 1988 by Congress. And if you look back on both federal strategy and federal funding, it particularly resourced and strategized criminal justice and supply reduction approaches. And it wasn't, quite honestly, until the end of the Obama administration, largely with the implementation of the Affordable Care Act, where we saw some parity between health approaches and criminal justice and supply reduction approaches. So we need to continue to advance kind of state, federal strategy and federal resources as it relates to that. As a former state director, I can tell you the importance of federal strategy, because states often look to the federal government in terms of what they are putting forward as it relates to strategy and resources. I wrote down on my notes here, resources, resources, resources. Regina talked about, quite honestly, the movement to deinstitutionalize people with serious mental illness. And that was an incredibly noble and right thing to do. However, the challenge was it's supposed to be an equal commitment to the implementation and the resource of community-based supports, which quite honestly never happened. And I think this topic is tremendously important, that while we see just this huge cry away from incarceration, we have to ensure that the resources are there to support it. And I will also say, while resources are, and I think have been coming as it relates to the opioid epidemic, kind of just focusing on kind of 1 or 2 year grant programs is often unsustainable for people to support the kinds of duration of community resources that we need. One of the things, and this is picking up where kind of Caleb talked about what happens at a community level, is the making sure that we have multidimensional partnerships with particularly people in the law enforcement community. Let me give you a kind of an example for that. Many of you have been, have seen just the role that many community law enforcement officers have played in the administration of naloxone. Some of you might recall that it was actually the police department in Quincy, Massachusetts, when I was here, that started, they were the first police force in the country to administer naloxone. Many of you have encountered Lieutenant Detective Patrick Glynn, who became the national champion for naloxone among law enforcement. So, our partnerships with those in the law enforcement community can be incredibly valuable in terms of kind of shaping law enforcement's view of kind of moving away from arrest and incarceration and embracing kind of public health principles and public health practices as it relates to people with substance use disorders. I also think it's important that we continue to look at healthcare system reform as it relates to substance use disorders, and really want to thank Dr. Harris for all of her leadership at the AMA in terms of moving that work forward. But I think it's really telling that even though a small percentage of people in the United States get treatment, if you look at referral sources, this is data from the National Survey on Drug Use and Health, the biggest referral source to treatment is still our criminal justice system at about 40%. And only 8% of referrals are coming from our healthcare delivery system, despite the fact that people are intersecting with our system all the time. Many of you, and I've kind of said this ad nauseum, many of you know my own personal story. Addiction is the disease of early onset and often goes undetected, and without systemic early intervention, it's often an intersection with the criminal justice system that people have any chance at treatment. So continuing to think about how we routinize the integration of early intervention and addiction care becomes particularly important. One of the other areas I think is worth exploring is regulatory reform for our current addiction treatment system. Caleb talked about the importance of lower barrier treatment, and I will say, if we fashion ourselves as a chronic disorder, you don't have to have 2 perfect A1C scores before a physician decides to treat you for diabetes. Yet we often require abstinence as a condition for people to enter treatment. I think that we need to continue not just with medication administration, but how we think about admitting people who might be motivated but are not quite ready to give up everything at this point, and not to predicate treatment admission based on someone's willingness to be abstinent. And additionally, continuing to focus on our discharge policies. We are still administratively discharging a significant percentage of people for exhibiting the symptoms of the disease that they have. So I think it's really important for us to not only look at admissions policies, but also to continue to look at discharge policies as we go forward. I will also talk about the need for enhanced research, particularly in terms of effective models for law enforcement and the criminal justice community to divert people away from incarceration. Certainly drug courts have been around a while. Caleb mentioned the law enforcement assisted diversion program, but I think that this is an area that's ripe for additional research. Some of you might be familiar, and perhaps we can send out a link, that in the mental health world, they've had what's called the sequential interceptor model for a very long time that looks at each part of the criminal justice system and the intersection points for people with mental illness, and then implements evidence-based programs. So I think that this is a continued area for enhanced research in terms of the work that we're doing. The last thing that I'll mention, just because it's always been a pet peeve of mine before we kind of move on, is, while we've seen the movement away from incarceration for people with substance use disorders, and I hope that continues, I think we've seen the dramatic increase in the use of involuntary commitment statutes across this country. So for those of you who are not familiar, these are state provisions that allow for someone to be involuntarily admitted to treatment if they're exhibiting imminent danger to themselves or others. In Massachusetts and in many other places around the country, unfortunately, people are still sent to criminal justice settings as part of their involuntary commitment. These are folks who don't have any sort of criminal involvement, but just because of their substance use disorders are often put in criminal justice settings to support this. So as we're talking about the continued development of community-based resources and supports, I think it's really important that we look at the overutilization of involuntary commitment statutes, which quite honestly don't have any demonstrated evidence of effectiveness in the long term and may actually exacerbate overdose risk, that we not kind of look to some of those kind of practices that many states are implementing in order to deal with people who are not ready to seek treatment. So thank you, everybody, for the opportunity. I look forward to the discussion and the questions.
Thanks very much, everyone. And I really like the framing that Dr. Harris said. This is decarceration necessary but not sufficient. That we all have to look at the systems and bridging that divide between public health, mainstream healthcare, and the public safety community. So I want to talk about that a little bit more and ask each of you about that. How do we do that? How do we bridge that divide? And some of this is going to take a little bit of giving up the reins. And individuals in the public safety community have had no choice in many cases but to address individuals with substance use disorder. As Michael said, too many of people are getting their treatment referrals from the criminal justice system. And that's fine, but again, not sufficient. So I want to, Michael, if you would talk a little bit about, if you could answer that question a little bit about how we bridge that divide. And then Dr. Harris, if you could talk about that, and then Caleb.
Sure. I'll go back to and just say a couple things. I do think that fundamental to this, Regina, in terms of bridging the divide, is really focusing. I think we've got to do some root cause work here and think about how we continue to reduce stigma, how we think about things like racial and gender equity as a result. Because I think fundamentally, if we're really going to kind of change policy, we've got to change public opinion as we think about people with substance use disorders, and particularly people of color with substance use disorders. I think that's foundational to the work that we're doing. I don't think that we can think about wholesale decarceration unless we think, and Dr. Harris talked about this, as we think about things like the social structures that really kind of lead to a whole host of negative outcomes. So not only focusing on racial equity, but equitable educational and vocational opportunities for people. Housing as healthcare becomes a huge issue. But I do think that we need to continue to develop ongoing and sustainable relationships with our counterparts in the criminal justice community. I don't think that we can really think about kind of entertaining, meaningful work here, unless they're at the table. I'll share this example. When we were trying to get additional resources from Congress for what became the Cures Act. And Regina, I think this might have been your strategy. We brought 50 police chiefs to the White House, and we unleashed them on Congress and asked sheriffs to advocate for treatment resources. So I think we need to continue to seek out kind of champions, advocates, and spokespeople from the criminal justice and from the law enforcement community.
So I will just amplify stigma, as Michael talked about. And of course, one way, one strategy, one tactic is education, accurate information. And certainly in the physician community, I think we see this at the AMA. We want to look at how we are educating the next generation of physicians and currently the current generation of physicians around substance use disorder and those who have a substance use disorder. And so I think that is work that needs to continue to happen in our own education. The other issue is willingness, and Regina, you hinted at this, to get out of our silos, right? We each have our own lens, as I started out with, in areas of focus, and I think we have to be willing to get out of those and do what I always call is silo busting. This is your responsibility. This is my responsibility. If we have sort of this seamless system that I put forth at the framework, if that happens and we have resources, and Michael did say this, but I think this is another thing, resources. It is not all about money, but you need money. We need a well-funded infrastructure. We've had decades of a lack of resources for mental illness. And again, I hate sometimes that we talk about them separately, but for mental disorders and substance use disorders, we don't have that, and we will have to do that. And so we need that foundation, getting out of our silos, the education. Then I will say we need to make, and I'm speaking mainly around the medical community, Michael talks about that 4%. We need to make the right thing to do the easy thing to do. And so we need to look at what are the barriers. Are there, we know there are some barriers around prior authorization and some of these are there other administrative barriers? I already talked about educational barriers. Are there payment barriers, that prevent us from doing what Michael talks about as routinizing this? So, and I wanted to point out that AMA recently partnered with RAND on a study regarding behavioral health integration. Why did we do that? I would just let you know that there's so much appetite in our House of Delegates, our policymaking body, but we convened a group of payers, physicians, patients, and plans to talk about value-based care. That was the reason for convening those folks. You know what the number one priority was? And people talk about it all the time, behavioral health. And so there's an appetite there. We just need to make, again, the right thing to do, the easy thing to do. And where we see barriers, we need to work towards eliminating those barriers and, again, making this a routine part of the system.
So that's a perfect lead in. Thank you. I think this idea is sort of going down to the micro level now about barriers. What I didn't mention earlier about low barrier buprenorphine is I'm trying to co-opt the word enabling. It is very enabling of jails and emergency departments, and we hope police, to do all the diversion work or to get people started on medications. There was this excuse in jails and emergency departments, why do I get them started on medications if I have nowhere to send them? We're trying to remove that excuse. We have a drop-in place every afternoon at the health department next to the syringe exchange. People can get started on medications or continue their medication. So we're trying to literally reduce those barriers, reduce those excuses. The other piece of that, though, in terms of resources, money, but also sort of knowledge, awareness, and understanding. And I'm very excited about something we've been working on for several years here that we really originally built with an Arnold Ventures grant around developing treatment decision-making for opioid use disorder, which is just what it sounds like. It's shared decision-making, which, Dr. Harris, as you know, is a pretty normal thing in healthcare. In most areas of healthcare, you need to understand your life-threatening chronic health condition, understand your treatment options, And guess who gets to decide what treatments you get? You do, as the patient. We do not do that for substance use disorder. You're poor and brown, you're lucky if you get methadone. You're white and have insurance, oh, go to your primary care doctor, they can do buprenorphine, maybe. So one of the tools we built is kind of low-hanging fruit. It's just basic shared decision-making. It's medications for opioid use disorder, treatment decision-making. We actually took that pilot work, worked with our State Department of Corrections for their community incarcerated folks in 4 jails. We just tested a half-hour treatment decision-making discussion with clients before release, doubled the chances they started medications in a month after. That then makes the Department of Corrections pretty interested, and that makes other people interested. If you can do something that minimal and have that effect, what if we actually really made care really robust and got everybody on board? And so the really micro thing that we do through our work providing technical assistance for the state opioid response grants is we're going into juvenile lockdown facilities and meeting with the medical and counseling staff and saying, you're going to be doing medications. There's going to be a mandate. So there's the stick. But then the carrot is, we're going to take 2 hours and talk with you about, no, we're not trying to invalidate the 30 years of substance use disorder treatment that you've been doing. We're trying to say you have new tools and new ways to do this that are going to really improve quality of life. So really, as you all are talking about at the macro level, getting right down to the micro level, having those tools, having the carrots and the sticks.
So Caleb, I want to follow up for a second on what you just said about knowledge, awareness, and understanding. And one of the issues that we have to be really careful about is, as we are seeking decarceration, is to make sure that we're not then thereby creating one system of care behind the walls for people of color and another system of care for everyone else. So if you could talk to us a little bit about what you're seeing in terms of knowledge, awareness, and understanding, and then perhaps Michael and Dr. Harris.
Tell me a little bit more about what you're thinking about in terms of how those inequitable systems would be sort of become manifest. I want to.
So are the result basically you're referring, you're building knowledge, awareness, and understanding of the range of treatment options for people, so that they are not being kind of siloed into you're a person of color, therefore you get methadone because that's what's available in your community.
Right. Yeah. I think the point is, and I should say that this sort of shared decision-making approach also turns out to be great language to educate people with. Because it's really easy for people to say, oh, methadone's just a crutch. It's liquid handcuffs. It's a bobbity-boo. It's like, okay, well, that's not actually your decision to make. And trying to get people to understand that everybody has a right, this is a healthcare condition, that everybody has a right to access all of those services, and that they need to be meaningfully available, and that there's really equitable and informed access. Particularly, these 3 different medications are provided in very different care settings and have different levels of effectiveness. We haven't mentioned long-acting naltrexone, much less evidence of effectiveness, and yet that's what's so often being used in the incarceration system. And yet there's evidence over and over and over again that the vast majority of people get a single injection. And so in effectiveness work, in the real world, how that plays out is it doesn't improve mortality outcomes because people don't stay on that medication. And yet it feels like a quick fix. And so to your point, we want to make sure that if we do this, we do it right, that people have options. Are there people for whom long-acting naltrexone is going to work well? Yes. Do we know how to do that matching? No, we don't. So we need to figure out how to provide a system of care that doesn't just penalize people when they relapse, that expects relapse. One of the biggest things that we learned, one of the most heartening things that I needed to hear from my interventionists was how potent it was when we started our shared decision-making intervention, which also included 6 months of care navigation. And they said, we are going to work with you whether you relapse or not. That was the most powerful thing for people. It wasn't all the facts and information. It's like, I have an ally here who understands my disease and is going to work with me. So there's developing those systems, but then there's also helping people navigate those systems. That's so essential. And we did ask for the first time in our Syringe Service Exchange survey, do you want help navigating services? And almost half of people said yes there as well. So a lot of people are interested in that. They know these systems are a mess. It's not a system. It's a bunch of crevasses. And they need help with that. So there is this real concern about this bifurcation and inequitable access. So I think it really is, it's also about creating demand among the general public and family and friends that they want these services available to everybody. It isn't just on the systems, it isn't just on the quote clients. As a society, we should be demanding this. We get people coming and saying, we still get a lot of NIMBYism about putting treatment clinics in communities, right? And it's like, you have a choice. You have people with untreated opioid use disorder in your community. What do? They use opioids. They use illicit opioids. You are denying them access to illicit opioids that you take orally once a day. They keep you stable. You're making a choice by doing nothing, and it's harmful. So it's nicely having those conversations.
Thanks. Michael or Patrice, you'd like to address them?
Certainly no easy answers, but I think it's important that we ask the question in the beginning. That's an important question. As we develop systems and decide the path forward, the first question should be, and how can we make sure, as best we can, make sure we don't have a two-tiered system here? Because as you know, in so many areas of healthcare, we do have a two-tier system. Now I would say, first and foremost, we know that so many patients who previously lacked health insurance were able to get treatment for a substance use disorder after the Affordable Care Act, through the expansion of Medicaid. So that's a piece of the puzzle. I talked about public health data and surveillance. Let's map. Let's see where these treatment facilities are, and let's see where the facilities. And then we can also talk about methadone and do we need. And this is a conversation. I'm not saying yes or no, but let's have a conversation about the amount of regulation we need. If you go back and look at the history of the Harrison Narcotic Treatment Act, I mean, that was sort of the beginning. That was stigma in action, stigma in statute from the very beginning. A physician can prescribe buprenorphine for any other purpose with no need for the waiver or the training, except for substance use disorder, and so again, that I think that was 1800. So that's a lot of history to overcome, but we have to do that. We're going to have to do that about equity, and we're going to have to do that around substance use disorder. And, one of the things we've asked at the AMA is, do we need the waiver? Actually, we have said we do not need the waiver. Now, again, we are talking about the waiver, in total. We can have conversations about what training is needed, but right now it's a barrier. And so we have to, decide, do we still need those barriers? So those are just a couple of things that we could do to make sure. But I think just asking the question from the beginning, as we are designing a system, is this going to end up being two tiers, is critical.
I want to kind of pick up where Patrice left off, because I do think, kind of asking the question, but also kind of evaluating the outcomes of those efforts become really important. And let me give a good example. I think many of you are familiar with the police-assisted addiction recovery initiative, Parity. This has been an effort by local law enforcement to actually promote and steer people to treatment. A question that we often asked was, do those same pathways exist for white folk as they do for people of color? So I think, asking the questions about, is this equitable, and the evaluation of some of these programs become important. Let me also say a couple other overly simplistic things to this conversation. I will tell you, during my time, I spent the past 3 years working at Boston Medical Center. We are the largest safety net hospital in New England, significant portion of our patient population, and we pride ourselves on treating people of color throughout our care institution with dignity and respect. But when you looked at what the composition of our addiction programs, we had significantly lower numbers of people of color than was reflected in our community and reflected in our own patient population. That prompted us to ask some really, I think, soul-searching questions about what our programs looked like. It required us to look at the composition of our workforce. Does our workforce look like our community? And does it look like our patient population? What are the factors? Lots of historic distrust, and rightly so, of our healthcare delivery system among people of color. And so how do we kind of continue to work with our community partners in terms of building trust and building faith, particularly in our addiction program? So, if we want, to really kind of create those kinds of systems of care, we have to make sure that they are responsive and respectful and look like the communities that we're trying to serve.
Thanks. Great. We have a lot of questions that our audience has presented, and I'm going to turn it over now to Shelley to field those questions. Thanks.
Great, thanks. And thank you everybody for your great remarks. Yeah, we've got a lot of questions coming in, so I'll try to field them, and folks feel free to put questions into the Q&A function. So I think, there was one question that came in and, which is really kind of the elephant in the room, right, with this conversation that we're talking about decarceration, where we have a system that criminalizes drug possession, and some people see it as criminalizing addiction. And while we have these programs like LEAD and Parity and other diversion and deflection programs, what are folks' thoughts about, is this the time to really take a critical look at the infrastructure of the system in general and really do a big overhaul to move away from criminalization? I don't know who wants to field that question. I'll start with Caleb.
Thank you.
I think well, I'm an academic. I think that the answer is yes. It's going to not surprise you. And I think what's really important when we do have the opportunity to actually dialogue with people is to acknowledge things, as Dr. Harris was saying, that the fact that it's a choice that heroin is illegal and that alcohol is legal. We know it's a choice because it used to be the opposite, right? Heroin used to be illegal and alcohol used to be illegal. And I think the entire point around, one of the major points around harm reduction isn't just reducing the harms of the substances themselves, but recognizing that much, if not the majority of harm, is actually caused by the criminal and societal response to people who use drugs. And as long as those reactions, and long as those negative consequences are in place, as long as we do have this two-tiered system, as long as we know that the Nixon administration was purposeful in this approach to the war on drugs, and that it is a continuation of this long legacy from slavery to Jim Crow to redlining to the war on drugs, that is all one thing with different names, I don't know how we make a meaningful change. So I would go with yes.
Actually, I think the question is easy because we actually, not the ultimate answer, but we absolutely have to look at it, right? We have to be willing to have an honest, evidence-based conversation about that. I mean, otherwise, what is the purpose? What do we do in health? What do we do in public health? We get the data, we look at the history, right, from years ago, and we pull that thread through and look at the impact and have honest conversations about that and then make decisions. So now is the time. I think we can include this conversation as part of an overall conversation on equity, on policies and procedures. We don't have to pre-decide what the answer is going to be, but we absolutely should commit to a full conversation about this.
I agree. I'm an unfettered former government person now, and I've often asked myself the same question of, to what extent do we really need to think about kind of the way that our laws continue to criminalize, drug use. I think that we have models in other countries that we can examine. I do think it's a worthy conversation. I will say one caveat though. I do feel like sometimes we jump 3 spaces ahead before we fully implement all of the things we know to be effective, right? So yes, while I think it's great to have these conversations and to look at that, like we know that we have things that we can do and things that work now, right? Where we don't have to have a grand experiment around legalization when, we know there are all these things that we can and should be doing. So I don't, what often happens is, I feel like we jump to the legalization discussion. And again, I'm saying I think these are really important discussions to be having, but we forget that there's 20 things that we could be doing in the meantime that we know we should be doing and we know work. So I don't want us to forget there's like a full spectrum of things that we can be implementing right now.
Yeah, let me just support that, because as Michael says, we have a habit in this country, I think, of pendulum swinging, right? And thinking all or nothing, or either or. And also thinking that we can't have full conversations. So I couldn't agree more with you on that, Michael. And the other thing, and I mentioned this earlier about language, and I think we should also have a conversation about what does it mean to be in treatment. Actually, I was giving a lecture one day, and I talked about getting into treatment, and one of the audience members said, what does that mean? And if a physician ask a question and ask me about my history of using substances, and if there is any misuse, this person said, I consider that treatment, so, that's just, and so I think we should also have more conversations about what it means to be in treatment, and maybe even stop using that phrase.
Let me just add one more thing here too. I also think it's important that we distinguish between decriminalization and legalization, right? Because I think that those are two dramatically different things. Personally, I've and from a policy perspective, I've been in favor of decriminalizing, marijuana use and simple marijuana possession, right? That's dramatically different from legalization and, quite honestly, commercialization sometimes of some of our drug issues, and my concerns around marijuana have always largely been around the commercialization of those. And, as a longtime public health person, I've seen how both with alcohol, tobacco, even with gambling, that has a disproportionate effect on some of the exact same communities that we are trying to kind of reduce those equities. So I think it's really important to also distinguish between decriminalization and legalization.
So, a few other questions came in about kind of large scale system restructuring. So let's focus on some of those, and then we'll get to kind of the work on the parallel track of working to make these improvements in the system as it is, as we kind of maybe reimagine or build something different. A number of questions came in around Medicaid and the way that Medicaid is structured, not generally paying for healthcare services or treatment while people are incarcerated, or the IMD exclusion. This is kind of, for folks that don't know who are listening in, Medicaid can pay for services in the community, but not in certain institutional settings, including jails and prisons. And some argue that that causes a bifurcation of the way that services are provided and paid for. Is this also a time now to rethink how we fund these services in the Medicaid program, but also overall? We have a lot of funding silos, not only program and services silos. And what should we be thinking about as we maybe try to transform some things? I don't know who wants to take that first one, maybe Michael, and then Dr. Harris.
Sure. So a couple things. I think it's really interesting as some states look at the development of their 1115 waivers. I'm thinking primarily of New York, have looked to include the provision, having Medicaid pay for some level of behavioral health services behind the wall. And for those, 1115 waivers actually have a cost neutrality rider to it. So it would allow states to experiment. And I think, I don't believe that CMS has ruled on that, but I think it's really interesting. There's also federal legislation, I think sponsored by Representative Tonko, that would look at allowing Medicaid to pay for addiction treatment 30 days prior to release. And I think the premise is not only is it good for people and the right thing to do, but it's also cost saving in the long run, and that it would reduce overall recidivism. I will say a word on IMD, though, because I do think that really just looking solely at IMD exclusions misses the fact that folks need a whole continuum of care beyond just inpatient residential services. And so, I think the way that CMS has approached IMD at the state level, I think, is really interesting. That says, look, we would be willing to waive the IMD exclusion, but we also want to see that you have an entire continuum of care. I think it's really important. Just, Caleb was talking about starting buprenorphine induction in the emergency department and not having, community-based services to refer people to. And I think the arguments with IMD are similar in the sense of, we don't want to have this huge funnel of people who get access to inpatient services and not have access to the whole host of community-based services that they need for their ongoing recovery.
Those are certainly important points. On an earlier slide, I had sort of the patient and the family, and the person in the middle, and then all the services that are critical to health, right? And I, dream of a world where in that center, diabetes is in there, and cardiovascular disease is in there, and substance use disorder is in there. They're all in that center. And then those are the systems that are critical to achieving optimal health, and everyone has an equitable opportunity to engage in those systems to get their health needs met. And so I think we start there, or we start with that as the vision. Certainly funding is critical. We need to eliminate all barriers. So the question was about Medicaid. Whatever the barrier, I would say just whatever barriers exist to someone getting the care that they need in the correctional setting or outside of the correctional setting is something we should be thinking about. And also, again, we need to look at Medicaid reimbursement, and again, reimbursement for the services, reimbursement for the making sure that they pay for the medication, making sure that there is support for the infrastructure and all the services around. As Michael said, it's not just inpatient, and let's just say not everyone will need that, right? And so we need to, I think that there is an automatic jump to treatment. Somebody in treatment means that they are in inpatient or residential. And I think, again, we need to sort of broaden the definition of what services or treatment is, and make sure that the services match the needs of the patient. It's not a one-size-fits-all approach, and we need to make sure that continuum is available.
And I would just, within that very briefly, not from a financing perspective, but from a continuum of care perspective, we're very happy to have about a quarter of the folks who attended our harm reduction conference were people who worked in housing and services. And to really think about what we need to do in terms of housing infrastructure is a major, major endeavor. And we had a second day, we had a panel of very different housing models, right? There isn't just one housing model. In my opinion, from what I've seen from people who are using substances, an abstinence-oriented housing model is a good fit for some people and a terrible fit for other people. So that can't be the only housing model we have that also is around addiction. And so I think we also need to be thinking about what are the various incentives and motives for sending a person to inpatient? And are there, for many people, more efficient ways to do that in the short and long term? So I just put that out there in terms of thinking about what are we actually trying to accomplish and for whom.
And kind of along those lines, we got some questions come in that I think I would put into the category of addressing stigma, and you all talked about that. There's some pretty pervasive ideas, I think, in the recovery community, a community that I'm a part of, about medications for opioid use disorder. There's also some pretty pervasive stigma in some of our provider systems, right? Whether it's in the treatment system or for example, how hospital emergency departments address addiction or opioid use disorder. We're seeing some trends with some hospital EDs really moving to have robust programming and warm handoffs and induction of buprenorphine, but that work is very difficult. It's slow, it's a culture shift. It's the same culture shift we're having to see in programs and services being provided behind the walls. And it's stigma and kind of internalized stigma, I think, in some sense, within the recovery community and in other areas. What are some best practices or successes that you all have seen or are working on related to addressing these issues in these different areas? Let's see, to start, maybe Dr. Harris?
Yes, and I think that's critical because people often want to do something, but they don't know how to do something. And I think a good practice is to show a system, an individual practice, a community, what's working. We've tried to do that at the AMA. It's been focused on, as we address the opioid epidemic, we had a microsite, and we were very intentional about putting up programs that were working. So that jurisdictions, counties, states did not have to reinvent the wheel. And so that is an ever evolving and ever changing proposition. But I think that, and we will continue to do that at the AMA, and hopefully others do. It's important for folks to be able to, put in either their state or their specialty or integrated care and find where they fit in. I'm actually on a couple of work groups right now as folks are looking about integration, and the key is there's some folks that are further along than others, some folks that are thinking about it, and I think it's an obligation on those of us who have and know about systems, programs that are working to get the information out there. And then folks can say, oh, okay, that looks like me. I think I can perhaps model what we want to do in my particular jurisdiction or practice on that. So I think that that's a key factor in folks adopting something. They will need to see if it's working, right? If it has worked. What were the mistakes made? What were the unintended consequences? We highlight a lot of programs on there, but in Virginia has since, of course, expanded Medicaid, but we were very bullish on what they did in Virginia before they expanded Medicaid, but knowing that they had this huge problem, and they just had a will there to change, right? And they decided that they were going to make sure that reimbursements were increased, and they wanted to increase the number of providers, and they wanted to make sure the medications were paid for so that folks could have access to evidence-based care. So I will just say on our website, you can find some programs and models that are working, but that's a critical piece of the puzzle, is showing people how it can work and how it can be sustainable. And I think we're still on our journey there, right? I mean, I'm not saying that everyone can do what another state or jurisdiction did. And it does require some resources, I think, at both the state and the federal level.
Can I just, to kind of ask specifically, when kind of facilitating these shifts of how practice is done, in particular in the kind of medical community, what's the right balance between mandates, kind of saying to all the hospitals in a state, for example, listen, this is it, you have to do it, X, Y, and Z, BUP and the ED, whatever it is, versus this kind of evolving culture shift and letting people kind of come to their own conclusions around it, which might be more sustainable, but not happen as quickly. What's the right balance there?
You probably won't be surprised to hear me say this, but I just don't think mandates work. I think that you need to incentivize, make the right thing to do, the easy thing to do. If you just mandate something and you just say, just do this, and absent an understanding and appreciation of all the barriers and others, folks will just say, you know what, we're getting out of this, it's too hard, right? I just won't include this in my practice, because we, of course, can't mandate that somebody does something in their practice that they don't feel comfortable with. So I think there should be no mandates. There should be incentives, again, education, roadmaps for how to do the right thing. I think that and it might be a little slower, let's admit that. So let's just say that. It might be a little slower, but I think if you're really interested in change and that culture change, I mean, in just a couple of minutes here, you know, we were having all these conversations around police brutality and equity and racism. And let me just say, that it is my prediction, and I think that, you know, just doing a one-day training and doing something that's just check the box, I call it sort of feel good, either legislation or something or intervention. Okay, we had a one-day equity and diversity training, check box, let's move on to the next. It's just more complicated and nuanced. And so I think if you, you know, culture trumps training any day. And so, and mandates don't help you change your culture. So it's harder work. It may take longer, but I think the outcomes will be better.
And the problem with people feeling they need to do it, even if it's not a mandate, but thinking they have to do it, we have seen, which has been, for instance, you know, jails dosing people at a very low dose every other day, and they're managing withdrawal. They're not managing opioid use disorder. And those are very different things, and people may actually have bad experiences in that context and not want to be on those medications, which could well work in a much more functional way going forward. That's one of the reasons we've been putting together educational materials for jails and prisons around, from all these different perspectives. What are the different reasons you might want to consider using medications for opioid use disorder? And I should say, the other thing we haven't discussed, but I'll mention it briefly, is I and we as our research and TA group are choosing to work with jails and police, even if we don't think that's where care should be being delivered. That's not, you know, we have the system we have right now. I think this is part of the culture change we need to create, is engaging with people so they see as well that, yes, we want to care for people who are here and they shouldn't be here in the first place. We need to fix these systems at the same time. So that's another piece of this that is a very difficult tension, which is when and how to engage with these different partners.
I want to be the contrarian here. It won't surprise my friend Dr. Harris. But I don't think it's mutually exclusive either. I think we need to make it as easy as possible. But I feel like we are so far down the road here, and we just still have not made significant progress. And I'm not just talking about the medical community. I'm talking about the criminal justice community too. You know, if you think of, you know, and I'm not just talking about mandates. I'm talking about things like litigation. I'm talking about things like legislation, I think become really important priorities. And you know, as I was thinking about this, you know, one, you know, we've seen some cases where the ACLU and others have actually taken jails and prisons to court over not allowing people to continue on their medications. And they won. And I will tell you that, you know, sheriffs, and I can speak to at least Massachusetts, people sit up and take notice and say, you know, yes, we need to incentivize, legislature gave them grant money, you know, partnering with the public health agency to do training, technical assistance and all that. And I'm not saying they don't need that, but, you know, there is a time and a place for mandates, for legislation, and for litigation. And I think, you know, if we've tried all the other stuff, you know, and that fails to keep forward, you know, I will tell you that on the mental health side, there is a significant amount of both federal and state legislation that actually protects people with, particularly with severe mental illness, in terms of their ability to receive services. And I don't think we've seen the same body of case law. I think we're starting to see it related to the provision of addiction treatment services, and particularly addiction medication. So you know, I think there is a time and a place for all of those things. But I do think that, you know, particularly when you know, we are this far into an epidemic and we still haven't seen the sea change that we need to see, there's a time and place. And I'll just end with this. As a medical center that does a significant amount of addiction work, our CEO and our chief medical officer actually mandated that the vast majority of our physicians go through the waiver training, and not to treat people with buprenorphine, but just we felt like everyone who takes care of patients should have some minimal competencies. And we thought we'd get a tremendous amount of internal resistance, and we did not. And I think it's, kind of people said, yeah, it's time to do that. And we certainly made it easy for folks to do it. So again, not to be long-winded, but I do think there's a time and place for mandates, legislation, and litigation.
Thank you. Thanks everybody for your thoughtful responses. We had a ton of other questions, and I think we probably could continue discussing these issues for a long time, and I know that we will. I wanted to turn it back to Regina to give the opportunity for folks to give closing remarks. Thanks.
Thanks so much for joining us. And again, we have a lot of questions that went unanswered. We'll do our best to make sure that those answers are replied to. We will have this event on our website at the O'Neill Institute, and we'll send that out to all the participants, as well as we may have the slides. We just need to get permission for them. But Caleb offered a bunch of resources in the chat box that we will also provide to folks if they want them, because they're useful resources for people. So I want to give folks just an opportunity for wrap up, and then we'll go in the reverse order. Michael, do you want to go first, then Dr. Harris, then Caleb?
Sure. Thanks, everybody. I'll just kind of sum in terms of what I think kind of Dr. Harris talked about, in that, we really need to take a much larger and macroscopic view of what health is in our culture. And, and for too long, unfortunately, in the mental health and substance use world, it's been our correctional facilities and our law enforcement officers who borne the brunt of the major impact for a variety of reasons. But if we want to that we have a unique moment in time where I think the aperture of the conversation is open now to thinking about all of these different issues. I think we have a moment in time when we really can kind of seize the opportunity at the local, state, and federal level to really move the conversation forward. So I want to kind of thank everybody for all of their thoughtfulness and all of the work that they're doing.
Let me too thank you for the opportunity to have this conversation where we are really, I think, visioning, and I think we are taking advantage of the moment. What will be critical is that we make sure we don't miss this moment. And there will be a lot of things on our to-do list as we get on the other side of the acute phase of this epidemic, but clearly and critically, and I've said there are three things, I think three buckets on the to-do list, and that is healthcare delivery and access, mental health, including, and when I say that, as you all know, everyone knows I'm including substance use disorders around that, and equity. And of course, all three of those are intertwined. And so we certainly have to make sure two things are clear. One is that all barriers to treatment must be eliminated no matter the setting. And we do need to think broadly about systems and not just the healthcare system. I think we need to think that every system is a healthcare system because every system impacts health. And if we start to think about that, centering our people and equity, and making sure that there are no differences between your treatment for your cardiovascular disease and your substance use disorder, I think that will get us a long way on our path forward.
And I think I would just say that we need to make sure that our care is person-centered and evidence-based, and that everybody has access to that care. And I feel like the best opportunity for that is to realize the multiple wins, the intersectionality of all this stuff we're talking about as a society, that the inequity can be undone with a lot of work and with a lot of resources. Clearly systems change, there's clearly financial resources, but we also then need the tools and trust people with substance use disorder to understand and be the best guide in their care. We have it the other way around. We need to really fully liberate people to actually be driving their own care and trust them. And I think that is something that we fundamentally don't do, is ultimately trust people, including people with substance use disorder. And that's probably the most dehumanizing and stigmatizing thing that we do. And that's, I think, fundamental to what we need to do to move forward. So thank you, and thank you to the O'Neill Institute for hosting this. I appreciate it.
Thanks very much, everyone. And the one thing that, there are lots of downsides to COVID. One good thing about these opportunities that we have is that we are able to bring people in an hour and a half from the Midwest, the West, and the East, and to get your incredible perspectives on these important issues. There were so many nuggets. As Michael said just now, the aperture of the conversation is open, and we really look forward to having continued conversations on this important issues as we move forward. So thanks again, and be well.
Wear your masks.
Thank you.
Had to get that in.
Yeah, good.